Hello, my name is Lori Matthews, and today I will be talking to you about caring for the pre-op and post-op patient. At the end of the presentation, you will be able to identify the three phases of the surgery procedure, describe safety concerns of the anesthetized patient, and define the role of the preoperative and postoperative nurse. Let's start with some definitions. The perioperative phase, which includes the whole surgical experience, including preoperative, intraoperative, and postoperative phases. Preoperative phase is the period of time from the decision to have surgery until the patient is transferred to the operating room table. The intraoperative phase begins with the transfer of the patient to the operating room and is completed when the patient enters the post-anesthesia care unit. Postoperative phase begins with the admission to the PACU and ends when the patient is discharged to home. The standards of practice are set by the Association of Operating Room Nurses, or AORN, in your hospital's policies. Safety is the number one priority when caring for patients having surgery. It is important to remember that older adults are more susceptible to anesthesia than any other population, and careful monitoring is necessary. Local anesthesia causes the loss of sensation without loss of consciousness. It blocks transmission along nerves, causing loss of autonomic function and muscle paralysis in the area of the body being worked on. These medications end in AINE, and some examples are Procaine and Lidocaine. It can be applied topically or by injection directly to the site the surgeon will be making the incision. Monitor for systemic toxic reaction due to CNS stimulation, which can be shown with the patient complaining of a headache, blurred vision, or a metallic taste in the mouth. Careful monitoring of vital signs is also important. Regional anesthesia or nerve blocks is the injection of anesthesia into or around specific nerve to block sensation, often for surgery on an extremity or to treat chronic pain. Assess motor function to ensure paralysis does not occur. Sense of touch returns first, followed by pain, warmth, cold, and finally movement. Other types of regional anesthesia are spinal anesthesia and epidural anesthesia. For spinal anesthesia, medication is injected into the cerebral spinal fluid, CSF, in the subarachnoid space to provide autonomic, sensory, and motor blockade below the level of innervation. Epidural anesthesia is medication that is injected into the epidural space in the thoracic or lumbar areas of the spine to block sensory pathways but leave motor function intact. We need to monitor for CSF leakage, and this will be shown by the patient complaining of a severe headache when the head of the bed is elevated. Moderate sedation is the administration of a combination of medications, including sedatives, hypnotics, and opioids, to the point that the patient is relaxed enough for the surgeon to perform the minor procedure without discomfort to the patient. The patient is still able to follow verbal commands and they retain their protective reflexes. They are easily arousable and, most importantly, they maintain independent breathing and a patent airway. Moderate sedation is used for minor procedures such as dental, podiatric, some diagnostic procedures such as endoscopy and bone marrow aspirations, wound care, and placement and removal of implanted devices can also be done under moderate sedation. General anesthesia causes loss of sensation, consciousness, and reflexes when a patient is having major surgery or surgery that requires complete muscle relaxation. Three phases of general anesthesia are induction, or the administration of preoperative medications and the securing of a patent airway; maintenance, where the surgery is performed and the airway is maintained; and emergence, where the surgery is complete and the removal of assistive airway devices is done. Anesthetics used are both injectable and inhaled. Inhaled anesthesia are volatile gases or liquid given in combination with oxygen. Popular inhalation medications are desflurane and sevoflurane. Exhalation eliminates the inhalation anesthetics, so the patient's pulmonary ventilation status determines how quickly this happens. Respiratory compromised patients will take longer to wake up. Postoperative administration of oxygen and encouraging patients to take deep breaths are important nursing interventions. Injectable anesthetics are given through the IV, and propofol is the most common injectable anesthetic at this time. Allergy to eggs is a contraindication to this medication. There are also medications that are given in conjunction with general anesthesia. Opioids are given to enhance sedation and relieve preoperative and postoperative pain. Some adverse effects can include depressed respirations or increased distress, a delay in waking up after surgery, constipation or urinary retention, and nausea and vomiting. Benzodiazepines are given to reduce anxiety, promote amnesia, and produce mild sedation with little to moderate respiratory depression with careful titration. Adverse reactions can include cardiac and respiratory arrest with rapid administration. Antiemetics are given to decrease postoperative nausea and vomiting, enhance gastric emptying, and decrease the risk of aspiration. Some adverse effects are dry mouth and dizziness. Anticholinergics are given to decrease risk of bradycardia during surgery, slow GI motility, decrease saliva, perspiration, and gastric and pancreatic secretions, and also decrease the risk of aspiration. Neuromuscular blocking agents are given to relax skeletal muscle during surgery and airway placement. Adverse effects are total flaccid paralysis, which requires mechanical ventilation because it blocks the contraction of all muscles, including the diaphragm and respiratory system. Communication, teamwork, and patient assessment are crucial to ensuring good patient outcomes in the perioperative setting. Ensuring that you take a complete health history for the patient's chart is important to ensure that all members of the surgical team have the information they need to provide safe care. This includes complete medical history, including all pre-existing medical conditions, all allergies, including latex, and any surgeries they have had and how they tolerated the anesthesia and any adverse reactions that they had. All medications, along with the dosages, need to be reviewed, including the last time those medications were taken, as they may alter the patient's response to the anesthesia. Medications that can alter anesthesia are pain medications, blood pressure medications, and diuretics. Perform a full assessment, including vital signs and level of consciousness. Determine the last time patient had anything to eat or drink. This is an important factor to help reduce the risk for aspiration. All preoperative diagnostic tests and blood work need to be performed, or if they were performed prior to coming in, the results need to be on the medical chart. If they aren't, the nurse must obtain those results for review by the operative team. Informed consent is essential to safe patient care during the perioperative procedure. It is the responsibility of the physician to explain the procedure in clear and simple terms, along with the complications to the patient, and have them sign the consent agreeing to the procedure. Oftentimes, the patient feels more comfortable clarifying things that were discussed with the doctor after they have left the room. The nurse is able to clarify any information that was given to the patient, but they may not provide any new information. The nurse will witness the consent after the client acknowledges understanding of the procedure. And the nurse needs to determine that the patient is over the age of 18 and or emancipated, is mentally capable of understanding the risks and options of this procedure, and that the patient isn't under the influence of any medication that can alter their decision making or affects their judgment. Patient education should begin as soon as the decision for surgery is made. It starts in the doctor's office and continues through to the time of discharge. In the preoperative area, this teaching includes the reason and importance of why every staff member caring for the patient will be asking them their name, date of birth, and what they are having done today. The purpose and effects of all pre-op medications need to be explained. Post-op pain control techniques, including medications, immobilization of the area if applicable, and splinting, coughing, and deep breathing techniques, and the use of the incentive spirometer. We need to start the discussion of the importance of early ambulation and any respiratory complications that could set in if the patient doesn't get up and moving around, and range of motion exercises if appropriate. Instruct the patient on the importance of anti-embolism stockings and pneumatic compression devices, or PCDs, to help prevent DVTs. Teach the patient about IV lines, drains, or catheters they may have when they wake up. Teach the patient the pain scale that will be used and obtain a baseline pain rating. Explain any restrictions the patient may have after surgery. All of the steps we take in the preoperative area is for the safety of our patients and providing care to achieve the best possible outcome for every patient. Postoperative care starts when the patient is transferred from the operating room to the post-anesthesia care unit, or PACU. This begins with connecting the patient to the monitoring equipment and obtaining a baseline set of vitals. The patient is identified by the staff accompanying the patient and the receiving nursing staff using the patient's bracelet, chart, and electronic health record. Following the identification process, a detailed report will be given to the recovery room nurse by the operating room nurse and the anesthesiologist or certified registered nurse anesthetist. Initial postoperative care involves making assessments, administering medications, managing pain, and preventing complications. The nurse performs a full body assessment with priority given to the airway, breathing, and circulation. Using the Aldrete scoring system, which uses 5 factors and is given a score based upon observations of the patient, once the patient has received an Aldrete score of 8 out of 10, they have stable vital signs, no evidence of bleeding, no nausea and vomiting, and their wound drainage is minimal to moderate. The patient may be transferred to the floor if the surgery was within the hospital, or to the advanced recovery room in an outpatient setting. Safety is a main concern for a patient recovering from surgery. As the patient is continuing to wake up, the nurse continues to monitor the patient, including vital signs and wound assessment. The nurse watches for any signs of complications. The patient should be assisted when getting out of bed the first time. The nurse assesses the patient's mentation and stability to ensure the patient is ready to get out of bed. The patient should be reminded of possible lingering effects of anesthesia, including dizziness, lightheadedness, and/or muscle weakness. Discharge teaching begins as soon as it's appropriate for each individual patient. At an outpatient surgery center, that could be as early as 30 minutes to 1 hour. In a hospital setting, that could be as early as a couple hours to the next day. Teaching regarding when to take pain medication and their side effects, any dressing changes that need to be done, activity restrictions that the patient has, and dietary restrictions is done until the patient no longer has any questions. Remind the patient the importance of attending their follow-up appointment with the surgeon and to call their office with any questions or concerns. Thank you for listening to this presentation, and if you have any further questions, please refer to your medical surgical nursing review module as well as your medical surgical nursing textbook and your instructors. Thank you and have a good day.